So getting at exactly what Zach was just asking about, who can we do this with? Men and women have very similar outcomes. Race, we don't see any difference in treatment outcome, but we noticed our African-American women were more likely to drop out early in some studies. But here's a problem. In those studies, we weren't always measuring for early completion due to doing better. So this may actually be an artifact of African-American women doing better in CPT than Caucasian women, faster. So same outcomes, but they get better faster. So that's something we're actually going to work on looking at in some of our current studies. Veterans from our current conflicts, in Iraq and Afghanistan are showing larger treatment gains than those from the Vietnam era. But again, that could also be an age issue. We know the older you are, the more fixed this thing becomes, less fluid. And so we know that the older you are, it gets a little bit more difficult to treat trauma with any therapy, but we still show very strong gains even in Vietnam veterans. We just show really great gains in the younger ones. And so I think it's important to say, get folks into trauma therapy as soon as we can. Let's not let them delay and get this thing more rigid, but also let the depression and everything else create itself around the PTSD. I already mentioned borderline personality disorder with some of the work that I was doing with the 2.5. It does not predict outcome at all. For those of you who've got all those myths about how horrible borderlines are and how they mess up and disrupt the milieu, they love CPT. Patients with this as a secondary diagnosis with any of the cluster B diagnoses do great in CPT. It's very structured. It gives them a lot to hold on to, a lot to account for, do really well. And we talk a lot about that in our training. Substance use, already mentioned that one. We absolutely take people who are actively using. We just say, don't do it during therapy and don't do it during homework, please. But we understand that need to sometimes be smoking marijuana, to be drinking. I have people with methadone who are using things inappropriate, like heroin, cocaine, bath salts. We just really try to get them to reduce, but I can't make that a criteria that they're completely sober before they start. Or, I wouldn't see a majority of my patients. And then I mentioned traumatic brain injury. That's a big one. But what about this? What about looking at other outcomes? So our patients with depression, hopelessness, suicidal ideation, guilt, anger, health issues, sexuality issues, dissociation, occupational functioning, social and leisure involvement, having well-being, having life satisfaction, intimacy issues. All of these have been assessed for, plus probably another 15 that I didn't have time to put, or didn't have space to put into this chart. All do much, much better when we do cognitive processing therapy. So it's not just a directed therapy at one disorder, it's directed at their life and how can we make their entire life better. Right? So what about pre-treatment? Well, as I already mentioned, if we have people with comorbid depression, we expect it. When you've got all that isolating going on from your amygdala overreacting and feeling like you have to avoid people so that you don't get triggered, people do get depressed. They do start to drink more. They do feel anxious. The group of clients that we actually delay on are those with active suicidal behavior, where there's an imminent threat. So do they have ideation when they come here? Yes. Do they have a plan when they come here? Yes. Do they even have intent when they come here? Yes. I'm looking for the imminent. If it's an imminent intent, we need to do something else, often inpatient. If it's a delayed intent, then we can start. Let's get going as soon as we can. And when some wonderful programs where they've got a tie between their inpatient unit and their outpatient unit are starting the therapy on the inpatient unit, and the same therapist is following them into outpatient. And it's just beautiful. The other group, current psychosis and current mania, that could also fall into there, that's unmedicated. Obviously, if someone's fully psychotic or in a full manic episode, it's very hard to do any therapy with them of a cognitive trauma-based sort. And so we delay just a little bit until we can get them more stable on a medication at that point, right? What other pre-treatment? We do want them to have PTSD. So this is a therapy for PTSD or subthreshold. I get that question a lot, is can I do this with someone who doesn't meet PTSD, but actually experienced some traumatic events? Some people have trauma, but they have depression, and they have trauma, but they have anxiety. We wouldn't use this with them. We'd actually use, obviously, an anxiety or depression protocol, right? But what we often do is talk with our clients about how this is different, how it might be a change from what we've done. We do a lot of kind of motivation of this can help, this can make you get better. And we even have a therapist contract where we make part of therapy responsible to us, that we're going to show up and we're going to get the work done and we're going to make it happen.